Chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease (COPD) is a disease state characterized by airflow limitation that is not fully reversible. Disease state characterized by airflow limitation that is not fully reversible, sometimes referred to as chronic airway obstruction or chronic obstructive lung disease. Pathophysiology. In COPD, the airflow limitation is both progressive and associated with an abnormal inflammatory response of the lungs to noxious particles or gases. The inflammatory response occurs throughout the airways, parenchyma and pulmonary vasculature. Because of the chronic inflammation of the body's attempts to repair it, narrowing occurs in the small peripheral airways. Over time, this injury and repair process causes scar tissue formation and narrowing of the airway lumen. Airway obstruction may also be due to parenchymal destruction as seen with emphysema, a disease of alveoli or gas exchange units. In addition to inflammation process relating to imbalances of proteinases and antiproteinases in the lung may be responsible for airflow limitation. When activated by chronic inflammation, proteinases and other substances may be released, damaging the parenchyma of the lung. The parenchymal changes may also be consequences of inflammation, environmental or genetic factors. Example, alpha antitrypsin deficiency. Early in the course of COPD, the inflammatory response causes pulmonary vasculature changes that are characterized by thickening of the vessel wall. These changes may occur as a result of exposure to cigarette smoke or use of tobacco products or as a result of release of inflammatory mediators. Chronic bronchitis. Chronic bronchitis is a disease of the airways. Is defined as a presence of cough, sputum production for at least 3 months in each of 2 consecutive years. In many cases, smoke or other environmental pollutants irritate the airways, resulting in hypersecretion of mucus and inflammation. This constant irritation causes the mucus secreting glands and goblet cells to increase in number, ciliary function is reduced, and more mucus is produced. The bronchial walls become thickened, the bronchial lumen is narrowed, and mucus may plug the airway. Alveoli adjacent to the bronchioles may become damaged and fibrosed, resulting in altered function of the alveolar macrophages. This is significant because the macrophages play an important role in destroying foreign particles, including bacteria. As a result, the patient becomes more susceptible to respiratory infection. A wide range of viral, bacterial, and mycoplasmal infections can produce acute episodes of bronchitis. Exacerbations of chronic bronchitis are most likely to occur during the winter. Emphysema. In emphysema, impaired gas exchange, oxygen carbon dioxide, results from destruction of the walls of the over-distended alveoli. Emphysema is a pathological term that describes an abnormal distension of the air spaces beyond the terminal bronchioles with destruction of the walls of the alveoli. It is the end stage of the process that has progressed slowly for many years. As the walls of the alveoli are destroyed, a process accelerated by recurrent infections, the alveolar surface area in direct contact with the pulmonary capillaries continually decreases, causing an increase in dead space. That is, lung area where no gas exchange can occur. That's called dead space. And impaired oxygen diffusion, which leads to hypoxemia. In the later stages of the disease, carbon dioxide elimination is impaired, resulting in increased carbon dioxide tension in arterial blood, that is hypercapnia, and causing respiratory acidosis. As the alveolar walls continue to break down, the pulmonary capillary bed is reduced. Consequently, pulmonary blood flow is increased, forcing the right ventricle to maintain higher blood pressure in the pulmonary artery. Hypoxemia may further increase pulmonary artery pressure, Thus, right-sided heart failure, carpal tunnel, is one of the complications of emphysema. Congestion-dependent edema, distant neck veins, or pain in the region of the liver suggest the development of cardiac failure. There are two main types of emphysema based on the changes taking place in the lung: panlobular or panacinar, PANLOBULAR, panlobular, panacinar, 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 and centrilobular or centroacinar, CENTRILOBULAR, centrilobular, centrocinar, CENTROACINAR, and centrocinar. Both types may occur in same patient. In the panlobular panacinar type, there is destruction of the respiratory bronchiole alveolar duct and alveoli. All air spaces within the lobule are essentially enlarged, but there is little inflammatory disease. The patient with this type of emphysema typically has a hyperinflated, hyperextended chest, barrel chest on physical examination, marked dyspnea and exertion, and weight loss. To move air into and out of the lungs, negative pressure is required during inspiration, and an adequate level of positive pressure must be attained and maintained during expiration. The resting position is one of inflation. Instead of being an involuntary passive act, expiration becomes active and requires muscular effort. The patient becomes increasingly short of breath. The chest becomes rigid and the ribs are fixed at their joints. In the centrilobular or centroacinar form, pathologic changes take place mainly in the center of the secondary lobule, preserving the peripheral portions of the acinus. Frequently, there is derangement of ventilation-perfusion ratios, producing chronic hypoxemia, hypercapnia, that is increased carbon dioxide in the arterial blood, polycythemia, and episodes of right-sided heart failure. This leads to central cyanosis, peripheral edema. Under respiratory failure, the patient may receive diuretic therapy for edema. Risk factors. Risk factors for COPD include environmental exposures and host factors. The most important risk factor for COPD is cigarette smoking. Pipe, cigar, and other types of tobacco smoking are also risk factors. In addition, passive smoking contributes to the respiratory symptoms of COPD. Smoking depresses the activity of scavenger cells and affects the respiratory tract ciliary cleansing mechanism, which keeps breathing passages free of inhaled irritants, bacteria, and other foreign matter. When smoking damages this cleaning mechanism, airflow is obstructed and air becomes trapped behind the obstruction. The alveoli greatly distend, diminishing lung capacity. Smoking also irritates the goblet cells and mucus glands, causing an increased accumulation of mucus, which in turn produces more irritation, infection, and damage to the lung. In addition, carbon dioxide, a byproduct of smoking, combines with hemoglobin to form carboxyhemoglobin. Hemoglobin that is bound by carboxyhemoglobin cannot carry oxygen efficiently. Smoking is not only risk factor of COPD. Other factors include prolonged and intense exposure to occupational dust and chemicals, indoor air pollution, and outdoor air pollution. A host risk factor of COPD is a deficiency of alpha antitrypsin, an enzyme inhibitor that protects the lung parenchyma from injury. This deficiency predisposes young patients to rapid development of lobular emphysema even in the absence of smoking. List of the COPD risk factors are: exposure to tobacco smoke accounts for an estimated 80% to 90% of COPD cases. Passive smoking, occupational exposure, ambient air pollution, genetic abnormalities including a deficiency of alpha antitrypsin, an enzyme inhibitor that normally counteracts the destruction of lung tissue by certain other enzymes. Clinical manifestations. COPD is characterized by three primary symptoms: cough, sputum production, and dyspnea on exertion. Dyspnea may be severe and often interferes with the patient's activities. Weight loss is common because dyspnea interferes with eating and work of breathing is energy depleting. The COPD progresses dyspnea occurs even at rest. The patient with COPD has a risk for respiratory insufficiency and respiratory infections, which in turn increase the risk for acute and chronic respiratory failure. In COPD patients with the primary emphysematous component, chronic hyperinflation leads to barrel chest thorax configuration. This results from fixation of the ribs in the inspiratory position due to hyperinflation and from loss of lung elasticity. Retraction of the supraventricular fossa occurs on inspiration, causing the shoulders to heave upward. Advanced emphysema, the abdominal muscles also contract on inspiration. Diagnostic findings. Pulmonary function studies are used to help confirm the diagnosis of COPD, determine disease severity, and follow disease progression. Spirometry is used to evaluate airflow obstruction. Bronchodilator reversibility testing may be performed to rule out the diagnosis of asthma and guide initial treatment. Arterial blood gas measurements may also be obtained to assess baseline oxygenation and gas exchange. Chest X-ray may be obtained to exclude alternative diagnosis. Alpha antitrypsin deficiency screening may be performed for patients under age 45 or for those with strong family history of COPD. In diagnosing COPD, several differential diagnoses must be ruled out. The primary differential diagnosis is asthma. A key part of differentiation is the patient history as well as patient's responsiveness to bronchodilators. Other diseases must be considered is the differential diagnosis include heart failure, bronchitis and tuberculosis. Complications. Respiratory insufficiency and failure are major life-threatening complications of COPD. Respiratory insufficiency and failure may be chronic with severe COPD or acute with severe bronchospasm or pneumonia in the patient with severe COPD. Another one is infection. Then the other one is other complications of COPD include pneumonia, atelectasis, pneumothorax and carpulmonale. Medical management. Smoking cessation is the single most effective intervention to prevent COPD or slow its progression. Patients diagnosed with COPD who continue to smoke must be encouraged and assisted to quit. First line pharmacotherapies that reliably increase long-term smoking abstinence rates are bupropion SR, nicotine gum, nicotine inhaler, nicotine nasal spray or nicotine patches. Secondary line pharmacotherapies include clonidine and nortriptyline. Regardless of the setting, the nurse has the opportunity to teach the patient about the risk of smoking and the benefits of smoking cessation. Pharmacological therapy. Bronchodilators. Bronchodilators reduce bronchospasm, reduce airway obstruction by allowing increased oxygen distribution throughout the lungs and improving alveolar ventilation. These medications, which are central in the management of COPD, are delivered through a metered dose inhaler by nebulization or via the oral route in pill or liquid form. Bronchodilators are often administered regularly throughout the day as well as on as needed basis. Several classes of bronchodilators are used: beta adrenergic agonists, anticholinergic agents and methylxanthines. These medications may be used in combination to optimize the bronchodilation effect. Some of these medications are short-acting, others are long-acting. Long-acting bronchodilators are more convenient for patients' use. Nebulized medications may also be effective in patients who prefer this medication method of administration. Corticosteroids. Inhaled and systemic corticosteroids, oral or intravenous, may be used to used in COPD but are used more frequently in asthma. Although it has shown that corticosteroids do not slow the decline in lung function, these medications may improve symptoms. A short trial course of oral corticosteroids may be prescribed for patients with stage 2 or stage 3 COPD. Inhaled corticosteroids via MDI, that is metered dose inhaler, may also be used. Examples of corticosteroids in the inhaled form of beclomethasone, budesonide, flanisolide, and fluticasone and triamcinolone. For stage 1 and mild COPD, a short-acting bronchodilator may be used. For stage 2 or moderate COPD, one or more bronchodilators may be prescribed along with inhaled corticosteroids if symptoms are significant. For stage 3 or severe COPD, medication therapy includes regular treatment with one or more bronchodilators or inhaled corticosteroids. Other pharmacologic medication treatments that may be used in COPD include alpha antitrypsin augmentation therapy, antibiotic agents, mucolytic agents, and anti-tissue agents. Thank you.